What you can see here is there's someone whose tongue is on fire, there's an ulcer in the mouth, there's someone holding the forehead and whatnot. So I just put this up there to create the impression that orofacial pain is sometimes extremely difficult to diagnose and frustrating for the patient, and sometimes even more frustrating for the provider, simply because you're not able to come across the reason why they have the pain. However, this is not always the case. So simply put, any pain associated with the hard and soft tissues of the head, face, and neck can be called an orofacial pain. And these tissues, it can be the skin, blood vessels, teeth, glands, or muscles, send nociceptive impulses through the trigeminal nerve, and which is interpreted as pain by the brain. So there's a very wide diagnostic range that can go from neurogenic, musculoskeletal, psychophysiologic pathology to headaches, cancer, infection, trauma, and even iatrogenic causes. So in short, the orofacial pain complaints involve diverse and complex physiologic relationships. Some of the complaints that patients come up to me with are that they have lost their wisdom teeth and now they've started noticing popping and clicking in the jaws, burning, stabbing pain in my tongue, which lasted just a minute or less, but just, the frequency has increased in some month. An IT professional who is at the computer desk for about 6 hours noticed jaw and neck pain, pain around the eyes, cheeks and upper teeth on the right side, sometimes the right temples too. Someone who has had a root canal, but the pain persisted. They've been to multiple providers, multiple treatments, and finally the tooth was extracted, but the pain is still present. And the doctors say there's nothing wrong in the patient's mouth. And then someone who chews gum every day, never had a problem, but these days find that their cheeks hurt when they move their jaw. So as you can see from the list of complaints, there's always some involvement of the teeth, the cheeks, or in and around the orofacial, region. And that's why many times it's the dentists who come across or who are called in for diagnosing these conditions, because patients don't know, and sometimes even providers don't know, if the cause of the pain or the source of pain is odontogenic or tooth related. So if what we see then is that dentists are very often the first clinicians to be consulted for neuropathic pain and neurovascular pain or musculoskeletal causes of pain as well. And this is where it becomes important to understand some basic concepts of pain, as in the very definition of pain and the biopsychosocial model. As you can see, pain is an unpleasant sensory and emotional experience. Now that is key here. It's both a sensory and emotional experience of a real or actual or potential tissue damage. And I like this definition so much because it speaks to not just a physical or a putative cause for pain, but something beyond that. And that's important when it comes to understanding the biopsychosocial modeling of pain or disease in general. Because traditionally, what many years ago, centuries ago, or even decades ago, we used to focus on the biomedical approach, where we had, there was always something wrong in parenthesis with the body, and the mechanistical model of pain was good so far as treating the tissue responses or the tissue damage, but it did not address pain in patients with little or no definable pathology. And that's where the biopsychosocial model of disease comes into play, where a person is a complex unit and the body cannot be separated from the mind. And this mind-body connection is extremely important for health. And why am I stressing so much on this? Because when we treat patients with orofacial pain, it is important to address all of these conditions and understand the language of pain. And we need to know that pain can differ or reflect differences in sex, culture, education, or the actual, physical experience of pain. And it's always expressed, as I said before, there's a physical, emotional, and a cognitive dimension as well. And you need to understand the responses to medications, attitudes towards healthcare, the multidimensionality of pain, and also get an extremely good insight into the patient's experience that the patient endures. And that's why the definition by Sir William Osler to me is extremely important. Again, is that it's important to know what type of individual has the pain rather than the type of pain the patient has. And with that, we can have a background of statistics as well from the US, where you have 100 million adults suffering from chronic pain, even orofacial pain, of which 10% is chronic and affects a quarter of the population. And a bigger component of this pain that's chronic is usually from painful temporomandibular joints, of which 6.3% are women. And very often now, or we keep hearing the persistent facial pain, and all about the neuralgias. These are names that seems to be coming up more often these days. And it's without understanding the anatomy or the neurophysiology of the nervous system. Also, I think it's difficult to actually pinpoint the causation of pain, and also when it comes to treatment and management. And in that sense, we need to understand that pain processing goes in two ways. There's a bottom-up pathway that goes from the peripheral transmitters to the brain, and top down as well, and the neural pathways that involve the transduction starting from sensory nerve endings, and then the transmission along the neural network to the CNS and upward, where it's get assimilated in the thalamus, and then the modulation that happens, and then the downward or the descending pathway that really controls pain. That's where we have the concept of the gate control theory. I don't want to go into all of that, but it's important because many times when you address a patient's pain, it's not about just looking at the peripheral. It's also important to address the central concerns as well. And when we talk about the different types of pain, everyone knows about the nociceptive. Any pain that goes beyond a certain amount of time that takes for healing can be nociceptive. And with modulation, it becomes neuropathic. There's a psychogenic involvement that comes into play. And of course, the time factor as well. And a practitioner should also be familiar with some of the terminologies that would we see in these kind of patients. That would be allodynia and hyperalgesia, etc. But to focus on the umbrella features of orofacial pain, I wanted to talk about the musculoskeletal, where you have temporomandibular disorders, neuropathic, and neurovascular. The psychogenic obviously needs to be stressed upon, because no one human being is would be happy with if their quality of life is not addressed. And although sleep is not a direct component of orofacial pain, it has its indirect effects on pain. As you know, if someone doesn't sleep well, they wake up all cranky. So coming to temporomandibular disorders, you have the joint pathologies, as you can see here on the left side of the screen, and the muscular components as well. But what exactly is temporomandibular disorders? These are a set of conditions that can affect the jaw joint, the muscles and associated structures, with pain being the primary clinical manifestation. It's usually characterized with joint sounds, limitation in range of motion, tenderness to palpation, and disc displacements, which are internal disc derangements. And there can be associated muscle pain and movement disorders, which can contribute or add on to the symptomatology. And it should be stressed that you need to know the TMJ anatomy perfectly to be able to know where exactly the problem is, and to understand that you get up to 20 millimeters of rotatory movement with the lower compartment movement, and the rest of it is translatory. And I stress upon this part because if you don't know where exactly your disc is, and to be able to read that information from imaging studies is extremely important. And if you go about treating this without knowing the anatomy, it could be a problem as well. If you look at the right side of the screen, what you see here is actually an anterior disc displacement in a sagittal view. We have currently the Inform network, which has come up with the most recent, I wouldn't say most recent, it's 2014 diagnostic criteria for temporomandibular disorders, which is an upgrade from the previous diagnostic criteria, which was research diagnostic criteria, or RDC-TMD. Now with the DC-TMD, we have a small upgrade when it comes to diagnosis, and that would be the headache attributed to TMD. This is important because many times patients who have temporomandibular disorders have associated headaches, and that gets confusing when they have a primary headache like a migraine as well, or if they do, even if they do not have a primary headache, very often providers tend to send the patients away thinking that they have a headache, and they don't think of temporomandibular disorders. And then you have the myofascial pain, which is a big component as well. In most cases, you're going to see trigger points in these patients. And then you have internal derangements of different types here. So with this diagnosis, it helps to actually classify the disorder that's out there and do the treatment accordingly. I always talk about this slide just to highlight that TMD is really associated with depression. Which came first? Well, it's debatable. But the fact that TMD and other chronic pain conditions like fibromyalgia, IBS, low backaches are clubbed together and are classified as central sensitization syndrome is important. So if you are treating a TMD patient, most likely or inevitably they may have one or the other of these syndromes, and that's something we need to investigate thoroughly, because a lot of the time the demographics and the family environment is crucial to treatment, and especially their personal characteristics with all of the attention focusing and catastrophizing are important as well. And that brings me to the next subdivision, I would say, of neuropathic pain under orofacial pain. Here you have a demonstrable lesion or disease. At least we can point out that there's something going on here. And based on symptomatology, you have an episodic and continuous. As a dental practitioner, what most likely a practitioner would see would be a trigeminal neuralgia under the episodic neuropathies, and burning mouth syndrome under the continuous continuous neuropathic pain. And there is another subset, something called the atypical odontalgia, which is not in the scope at this point, but I do want to mention that the complaint that I earlier showed you about a patient coming in after root canal treatment, seeing multiple providers, finally the tooth was extracted and still the pain continues, is most likely a case of atypical odontalgia. And it's important to know this, and for that you need to really have an interdisciplinary craniofacial team out there, because you want to know if it's paroxysmal, whether the trigger points and unilateral, and imaging studies are obviously crucial for this. So once that is ruled out, or different entities are ruled out, we can narrow down to certain specific conditions, and that's when we can treat them. Neurovascular pain, or all the headaches that I was talking to you about earlier, are confusing, and we need to, confusing in the sense because many times it gets overlapped with different symptoms, and especially so for a dental provider or a orofacial pain practitioner, because of the referral patterns, as you can see, to the teeth and the jaws. So when patient presents with only pain in the teeth, it's natural that we tend to focus on an odontogenic cause. I would stress that any orofacial pain specialist needs to rule out odontogenic causes first for obvious reasons, and then expand your search out to different other entities. And as you can see, all of these different headaches have referral patterns to the oral region as well. So this is a clinical scenario here. I just want to quickly read this out to you. 41-year-old woman, strong pain around the eyes, forehead, and maxillary teeth, and started at the age of 15 years. Pain is accompanied by photophobia and nausea. Now you get a fair sense of where this is leading to. But she also has TMJ, as diagnosed by her doctor many years ago, used to wear a mouth guard, and the pain increases on chewing. Significant medical history is hypothyroidism and on pills for 5 years with no change in headache parameters. And she has a familial history of as well for migraines until menopause. Now, with such a patient presenting to your clinic with obvious headache, primary headache symptomatology and TMJ, it's very crucial that both these conditions are simultaneously addressed if possible, so that the patient has a better quality of life. Because if you're going to focus only on migraines and not give adequate information or attention to the temporomandibular disorder, this patient is never going to be relieved of that pain that most likely she has in the temporal areas as well. And there are a lot of other factors in this, but I can go into this if anyone has a specific question about this particular clinical scenario. So what do we do when we don't usually find a visible, measurable etiology? There are many things out there we tend to turn upon and let the patient go, and they end up doctor shopping. Finally, what I want to talk about is, are we treating the patients, are we managing the patients, or is it a combination of both? Most often in orofacial pain, I would say that we are managing the patient, because it's not about just addressing the patient's clinical symptom, but also addressing their quality of life, their mental status, the stress factors, sleep, etc. So it's a combination of both. Unlike many other probable other conditions where you focus on treatment or the cure. So that wraps up this particular overview. And if you see here that what I wanted to stress upon, many patients do come up and say, "Dear doctor, you don't know better than me." So they are out there telling you what they want, and that's something we need to address as well. And you have the brain that's really fatigued. And that's about it. Thank you.
Thank you, Dr. Kurup. If anyone has any questions, please feel free to unmute yourself and go ahead and ask your question. You can also type it in the chat box.
Yes.